Hello, everybody. Welcome back to Psychedelics today. Really excited to have our guest today, CJ Spotswood. CJ, welcome to the show. Feel like it's been a long time coming and excited to have you on. I feel like you've already been on the podcast, but maybe haven't. I feel like we've definitely done a lot of recording for some of our classes and whatnot. But yeah, I think this is your first time on the pod, right?
It is. It is. I've done a lot of recording with you and uh, live things like that, but I have not been on the podcast. I haven't had anything really to share.
Well, now you do. You have this
Yes.
wonderful book out called the Microdosing Guidebook. So before we jump into some of your, the book and your work here, would love just a nice background, who you are, how'd you get involved in psychedelics, where your interest really, how did that evolve, and yeah, just a nice little background in history.
So I'm CJ Spotswood. I've been a psychiatric nurse for about 20 years now, and in the last year, I've transitioned into being a psychiatric nurse practitioner. I've got a practice here in Maine where I'm seeing patients within the family medicine setting. I've been excited and interested in psychedelics for a number of years, but I really got into it more about 5 or 6 years ago. I had a patient come in who had been first time psychotic break in his late 50s, early 60s, and after he came out of it, come to find out, he revealed that he had been using penis envy mushrooms when we talked more about it. I started looking into the research of it. I started getting into like more of the history into like the 50s and the 60s, and this was right before Michael Pollan's book came out, and just kind of jumped in full force and trying to figure out my way around. So it was really interesting kind of a way to get in, and I got in at a really interesting time where it was kind of unknown and really can't believe where we are at this point. It's just jumping so quickly.
I know it's crazy how the field has evolved within the past few years. Didn't think we would be here. Curious just around your client, and you mentioned he was experimenting with penis envy. I know he was older, and I know we kind of chatted the other day on our Instagram live. That seems to be kind of an interesting case because they were a little older to have a break. And so, do you think that experimenting with psychedelics really kind of influenced that? There is kind of like that talk track that psychedelics could potentiate psychosis in people. What do you think was going on there? Do you think he had a history of that in his family, or?
He didn't. I mean, that was the interesting thing about him is when he came in, he was acutely psychotic, which wasn't abnormal working. I worked in an emergency department at that time, doing a psych nursing in a little unit within. And trying to figure out what was going on because we came in, he was acutely psychotic. We started, trying to figure out because talking to him, he wasn't much help with that, trying to give us information. So we had contacted his brother and talked to his brother, and there was no history of psychotic thinking, no history. We didn't have him in our system for anything psychotic. We had everything medically going with him, just standard medical stuff. Started talking to the rest of the family, doing a drug screen. Nothing was there. Started working out medically, trying to figure out if it was a head injury, trying to figure out if it was lab work was off, something like his liver enzymes, etc. And couldn't really figure out anything. And we started medicating him, and then 2 days later, he had told 2, 3 days later, he had told us that that was the case. And the only thing we could really figure out was it was kind of a prolonged psychotic trip as a result of it. Talking to him, he swore it was mushrooms. I believe him completely. He trusted his source and everything, but I think it was just kind of a perfect storm of just not good for him of how it worked out. And
Yeah, yeah. Sounds like he may have had a pretty overwhelming experience, and good reminder that things like that do happen to people, right? Yeah, set and
yeah,
setting
it's
101, and your intention, and how you work with these, and especially for a very potent mushroom strain like that, right? Like possibly overdoing it and being too.
yeah, I don't know how much of dosing wise of what he took. He had no idea. He had his friend told him what to take, and I don't know if it was comparative like a regular cube by weight, and what he had taken was actually being penis envy, being stronger. Um, Unsure exactly what had happened. The amount, and no way of knowing at this point either.
Yeah. And you said this was kind of like a little bit of your first introduction into psychedelics. Like what was going through your mind then? Were you thinking that the like, psychedelics are bad? And I'm sure you started to dig into the research and maybe found some of the therapeutic use, but what was going through your mind as a nurse back then?
It was well, it wasn't really my first time with psychedelics. It was my first time really kind of hearing the use of it as being a therapeutic use as opposed to being more um, having fun or experimental things like that. College was one heck of a time every time I've gone, and I talk about that a little bit in my book. But it was the first time I'd actually had someone who really said this is what they were using and why they were doing it was for therapeutic reasons to help with his depression. And I knew about the research from back in the day, but it was kind of being the growing up in the 80s, this is your brain on drugs with the egg in the frying pan, kind of really changed my view or my thoughts of it, and kind of really, I guess I was kind of discrediting the research back in the day because it was, put to me as nothing was good, and in my history it was fun use things only, not as a tool, as a therapeutic. And the other part is kind of clouded because everyone. This is also during the time we had a huge outbreak of spice here in Maine, and so we had a lot of people who were coming in psychotic on spice when that was going on, which was not fun working in the emergency department dealing with that
That must have
outbreak.
been a time.
It was. I mean, really, the treatment at that time was, you m- medicate and have to restrain until someone's acutely down because of the absolute danger that they pose to themselves and others when they came into the hospital in that way. It was almost every other day we had someone coming in and with acutely on spice and things like that, and it wasn't a good time with seeing that. So my view of drugs, I guess, at that time was kind of really hampered and out of my mind, out of my where's the therapeutic use of these things, you know so yeah, it was
It's
it was
interesting
interesting.
working. Yeah, it's interesting working in like different kind of like emergency services or working with like crisis where you see like, maybe one section of the population and thinking like that could be the majority at times. Like you're seeing one kind of like population that's having like really bad reactions and coming to the emergency room and kind of shaping some belief around like what are the actual effects of these substances. And just thinking, I'm thinking about my time in different kind of like crisis management roles and kind of putting some generalizations over certain experiences.
Oh, it's the absolute worst setting to be in. When
Yeah.
we have someone coming in who, you go into an emergency department that is loud, bright noises, bright lights, loud sounds. Who knows what's going on? People in pain and going through their own processes, and then you come in there when someone. It's probably the worst setting to be in that acute state, which then just makes things escalate from there. But it was very interesting, and and you know, it is, you see 1% of the time someone has like one of or 2% of the time someone comes in with one of these, and then you see the worst of the worst coming in, and not the people who are, at a show and a lot, having a good time and having, being with other people. They're here in a scary situation coming in, looking for help.
Yeah. Yeah. This is more on a personal note, but you mentioned your college days, and I just thought that this was a really fun synchronicity. During the summer, I met up with my old college roommate, and his girlfriend actually knew who you were because you guys went to college together. And I was like, oh, that is funny worlds colliding in synchronicity like that.
Oh, it absolutely is. Yeah, she actually got a hold of me the other day because she wanted to get a copy of the book for one of her friends for a birthday present and had to send it to her. Yeah, it's a small world. It absolutely is.
It is. Well, maybe that's a cool segue into the book.
Yeah.
So, microdosing. How did you develop your interest in microdosing, and what inspired you to, write this microdosing guidebook?
Well, I ended up, I had a friend reach out to me who she was working as a microdosing coach and life coach and all these other things. And she had this project that she was looking at doing. She was kind of helping people with microdosing, and she was getting all these questions of like drug on drug interactions, medical, background, and I have XYZ going on with me. Can I microdose? And she realized that she was way over her head. So a friend of a friend got us in contact, and she had said, here I'm doing this project. I want to bring you in to kind of just help with it, help with the drug on drug, and answer these questions. I have no experience of how to do it. And at the time, I was kind of like, I'm interested. You've piqued my interest on this, but at the same time, my interest with microdosing was kind of framed by this. It is all the placebo effect. It's something that is not really. The effects aren't necessarily real, and I went into it kind of go like, let me see what I can kind of figure out, and ethically, am I like open to this, because I want to believe in this if I'm teaching it. So I ended up getting into the research and going in and starting, of course, at the beginning with James Fadiman's Explorer's Guide from in 2011, and then getting into like Torsten Passey's book, the history of microdosing, and going into the old research just like I had before, and kind of going, there is something to this. I don't think that this is just a placebo effect. I think that this is something that can have some great effects for people, and I think that it's the research does not know what it's looking for. I think that the research is since it is so difficult to research because of the being Schedule 1 designation, people don't have access to doing it. But also, when you're using this tiny amounts, what are you looking for? And when you look at the early research into the 50s and the 60s, they were doing microdosing research. They just didn't have a title for it. They were using placebo levels. They thought they were using placebo levels, but they were actually looking for threshold levels, things like that. But really, it was what by today's standards being a amount that we would consider as a microdose. And I kind of was like, there is something to this. And I started believing it as I read it more, that there is some great benefit to it, and the science backs it up. So it's really how I got into it. I ended up putting together this handbook for this course I was doing with Tara Lee. And as I was working on this handbook, and helping some people, kind of helping with their dosing, I really was looking at, I wanted to say to people, I'm not giving any medical advice. I am not your healthcare provider. You are not my patient. So I want you to really go with this, this information, and talk to your healthcare provider from it. And at that point, I was putting together this handbook to kind of help answer questions that people might have, just so that way, ease of time when we're meeting, they didn't necessarily have to ask the questions, like the preliminary questions for, how do I find a dose? How do I go about? And I'd said to them, if you're when talking to your healthcare provider, if they have any questions, where do they go? Here, bring my handbook, bring this, print it off and give it to them so they can answer it. And that's when I had a light bulb eureka moment that I went, holy crap, this is bigger than what I'm thinking. Like this, if I really did this right, would be what I would want if I had a patient looking to do this and brought this to me so I could help support them.
Amazing. I jotted down a few questions here. One, this just kind of popped in my head. I wonder, like, with medication, are there any other like medications that if you do take a microdose, there are like physiological effects on the system and actually has benefits? So just thinking like, with psychedelics, they're interesting molecules because we're looking for this type of drug effect, right? We're looking for, distortions in imagery or some sort of visual type of distortion, some sort of, experience. But like, do we know actually what's kind of happening like in the body at these smaller doses versus trying to get to a psychedelic effect? And are there other medications outside of psychedelics where actually maybe microdoses of something actually are beneficial? It just makes me think of like looking at like microdosing in a different perspective of like we do try to look for the drug effect, but yeah, could there actually be some small physiological changes in the body with these smaller doses?
Well, I think if you look at, that was kind of the challenge of part of writing the book was finding this type of information that's out there because it was so limited. So I took the approach of using, what we have for both LSD and psilocybin because they are so structurally similar, and kind of going from there, extrapolating the information from there. And if you go into some of the information and some of the literature, you'll see that with the stimulation of the serotonin HT2A receptor, there is still some dendritic growth, even at small amounts, that are happening on the neurons. You're seeing a uptick of serotonin that's there. You're seeing some of these improvements that are happening. Also, the anti-inflammatory effects that are going on, which makes them so much different than the standard treatment of SSRI medications that are just uh, increasing the serotonin within the receptors of the brain. You're actually kind of stimulating for that end of the growth that's going on, which is why we potentially will be seeing these improvements downstream being so different, and why there's so many different applications that could be from, as anti-inflammatory. I mean, at this point, we don't even exactly know, what is depression per se. We have some hypothesis, and we know that by increasing the serotonin within the brain, for some people, you can have some improvements. But when it comes to depression, around 70% of people have effect with standard SSRI medications. There's still 30% that don't, which gets thrown into this classification of being treatment-resistant depression, which I don't like the term when we use that, because when you're looking at the standard medications like SSRIs, SNRIs, they're basically all the same. They're all these Me Too medications. So when you say that someone's treatment resistant for 3 medications, 4 medications, that are all basically working the same pathways and in the same amount, is that truly treatment resistant, or are we just doing trying the same thing with just different medications? Whereas, doing microdosing is a different pathway, is a different approach.
And just that term treatment resistant, like, I've noticed like people in the past getting really attached to kind of diagnosis labels. And what happens when we label somebody as treatment resistant, right? It's like we kind of almost say like, you're suffering from this depression that we don't have any treatments for. And does that actually give hope to somebody? Because there's so many factors to our mental health, right? Like environmental, maybe chemical imbalances, and what's going on physiologically. Like there's so much that's actually going on here. And yeah, what happens when we do label people as, oh, we don't have treatments that can treat this? Does
And
that
then you
give
go
them
to
hope?
Well, then they go into a different clinician. They see this history as well. They could either be this clinician going, oh, I'm going to, be the one that makes a difference, which is problematic, or they're going to go in and go, they've tried everything. What am I going to do differently? So, it is both ways. It's a tough, you want to treat it, but you're also going in knowing, you know, is this? And then the other question is when you look at like someone who has been on different medications, have they ever had true med trials? Have they ever tried, increasing the medication is, to a maximum amount or maximum tolerable amount, or they try it, someone has some side effects, go, yep, I don't take this, which I see often too in my practice. I have patients who, they didn't see an effect or they had some side effects. Might not even be from the medication, but they stopped it, 25% way of maximum dose. And they're just like, now I'm not going to do it. And I've had some luck with some patients coming back around and going, I know you've tried this, but let's try it again. And let's kind of look at it differently, and had a good effect with them once we kind of had that conversation. So it really, that labels do stick, and labels are tough.
Hmm. Yeah. Yeah. Not to downplay, like, there are people that are very, very, sick or hurting, and not to downplay, somebody might actually really appreciate that label, and to really take that seriously enough. But yeah, just exploring,
Well, on the other
language and
side,
context.
the other side of it, someone who's depressed, they have, that lifelong they identify as it, and moving forward, they've lived with it for so long, it's difficult to change that because they've lived
Hmm.
as having that depression. And what does that mean for their life moving forward by no longer being depressed?
I've heard that from, some people in the past, like, who am I without my depression, without my anxiety? And that's an existential crisis for a lot of people. Like, I wake up and I don't feel this way. Like, what
Mhm.
am I supposed to do all of a sudden?
Yeah,
And that can be actually really, really scary. It's like, oh, whoa, like I need to form new habits. I need to, form new behaviors, and I don't know how to do that. But I'm also
yeah,
not feeling as depressed. And,
yeah,
that causes a whole other slew of issues,
of
which is,
course.
really interesting. Really interesting. So you mentioned a little bit about the science that backs up microdosing. I'm wondering if you can dig into the science that has been exploring microdosing, and what are some of those research studies?
Well, I think there's all these things that we've looked at, and there's the research that kind of looks at the different changing of the personalities that have occurred, more openness with psychedelics, etc. But it's a couple of the things, the research that really sticks out to me more recent is there was a study that came out, Imperial College of London, I believe it was last year or the year before, where they were looking at pain management, potentially with it. And when they were having individuals submerging their arm in an ice bath, with after taking a microdose, they were able to keep it submerged longer, showing that there's a reduction in that pain that's going on. And I think that this is, looking at that, and then the recent study that came out with Dr. Castellanos, and Joe had spoken with court recently, and kind of looking at people who are doing large macrodoses of psilocybin with follow-up microdosing, and people are having less pain as a result. I think that this is going to be an area that can be very useful and very exciting because, the current treatment that we have for pain management is, not like mental health, is kind of lacking and limited. Our options are, doing the opioid medications for chronic pain, which, as we know, goes down over time in its efficacy, and pain becomes more problematic. But if we can have these different things without hitting that reward pathway, and not reinforcing addictive properties, and actually the having the decreased inflammation as a result, we can have, that's where I'm kind of excited to seeing is some of these applications coming forward. And then the other study that really came out like in the last week or two was the low doses of LSD, increasing the reward pathways in brain activity. And kind of Dr. Connor Murray out in Chicago with Harriet DeWitt and others, they were looking at how low microdoses of psilocybin or with LSD can improve the pathway of reward, which is a problem with people with depression not being able to have that good side coming out, reward of feeling good. And when they found what might be is the optimal dosing with it was between 10 and 13 micrograms of LSD, which I think is kind of an interesting way. If we look at this completely different, this wasn't even a way that in writing my book and exploring the how microdosing might affect depression. I didn't even, that wasn't something on my radar. It was kind of looking at more of the growth in the brain, and having inflammation going down, not that. So it's, I think this is going to be it was a small study. It's going to be interesting to see if repeating it moving forward and what that actually means. But I think it's going to be good for lay, helping us look at what is depression, and what is microdosing doing, and moving forward, what else can we have for applications with it.
Yeah. Do you believe that psychedelics help us understand mental health issues a little bit more? Because, this does get into like this issue of like the hard problem consciousness, soft problem consciousness. Like, what is going on in the brain? Is this affecting our mood? And how can psychedelics actually like inform us on this?
Well, there's a couple that leads me a couple of things. If we think of going back to the research, we wouldn't have found. Well, I mean, eventually we would have figured out what serotonin was, but that was because of the LSD research being done. We know what serotonin is. And how the receptors are throughout the GI system heavily, and why there's so many side effects with both psychedelics and SSRI medications that are GI heavy as a result, because of that's where they are. Um, but I think that when we look at what with mental health and psychedelics, I think that the other question of that is going to be, is the trip necessary for it? And
Hmm.
I know that there's people that are saying that
That's a controversial question.
it is controversial. What without that, I think, um, and I think it was Bill Richards had said was, that's where you really change your thought process of what's going on around you and why it is important. Because it's not just, otherwise, it's just kind of the Western model of medications. We're affecting the pathways, and we're seeing this reduction. But with it, doing the psychotherapy piece of it, or changing the way that we perceive something, either the world around us, or our perception of how we perceive pain, etc., that can change how we are, and that might be the more, I'd argue, the more important part of the treatment, not just having the medication doing its job on those pathways. It's the
Yeah.
meaning
Well, I
making.
mean, couldn't some of the argument around microdosing be kind of similar, of people taking these, sub-threshold doses, not having the psychedelic effect, but still getting benefit?
Oh, absolutely. I think that is, microdosing um, is kind of that, more of that Western model, in that, the medicine's kind of doing the work, but you need to kind of do the psychotherapy piece of just kind of putting the pieces together. But there's lots of people who can't benefit, or shouldn't go on a large dose journey, or it wouldn't be conducive to their lifestyle. If with the microdosing, yes, someone who's got neurodegenerative properties, things like that, some of these individuals, might not be medically well enough to do a large journey, or it might be uncomfortable for them to be doing a large journey. So if you end up, doing the microdosing, you can get maybe some of the benefits at a slower pace, having some improvements moving forward. But I think that, maybe even the other part is having a large psychedelic journey followed by the microdosing, and having that improvement, and then holding on to what the growth that's happened, the connections that are made within the brain moving forward to really change how it is.
Yeah. And as you mentioned, I think there are certain kind of like medical issues that, yeah, would you want to be taking a psychedelic all the time? Like one that pops into my mind, migraines or cluster headaches, right? A lot of physical pain. Does somebody want to go on to a huge journey? And I don't know, I do have some friends, colleagues that suffer from migraines, and they do treat with psilocybin. And you could get into an argument around like the transpersonal healing effect of it, but also they do come back for a lot, and people do
Yeah.
have to redose, and do they want to keep going on like these internal journeys,
Oh,
and having some sort of medication that could help, I think, is interesting. And not to write off some of the biotech plays that are looking at non-psychedelic psychedelics, but if they could improve a life of somebody that's really struggling with cluster headaches, that where they want to possibly kill themselves because the pain is so much, I don't think we should be writing that off completely.
oh, absolutely. No, absolutely. And it's, I think I just saw on Twitter someone was talking about using reserpine, that's the HT2A blocker, and kicking off LSD so you can shorten the trip. And it's kind of, you know is that going to be a play? Is that going to be something that's, people are going to be looking at doing as well? You know is that going to be a benefit of doing that? um
Is
I
that from
don't
like
know.
MindMed for like their trip stopper, or?
um I don't remember. It was like that, but it was, someone had posted how they had just did the research, but it's, with it, even by taking it, the trip has to go for about 2.5 hours, which can be difficult too for someone, especially if it's fully mind manifesting psychedelic journey there. And at that point, what are we, what is the benefit of doing that versus maybe, the businessman's lunch of DMT and blasting off in a half hour and coming back either. Lots of questions to be had as we start seeing more coming up and having what's the best psychedelic for people to have benefit? Who would benefit
Yeah.
from psilocybin versus LSD versus DMT versus ayahuasca, etc.
Yeah, and let's come back to that because I know we did want to talk
Yeah,
about scalability and
yeah,
accessibility, and I think these questions do kind of fit into that. Just curious, also, just going back to research, and then I want to go back to the book, and maybe from a client's perspective, how to talk about this with your practitioner. But some other research, like what was your take from the research, the largest, I think, self-blinded study ever, with Dr. David Arizzo, Dr. Balazs Segedi, Imperial, and I forget what the results were, but it was almost on par with placebo. And so, how did you interpret some of those results?
Well, the interesting thing is when that study came out, it was less than a week, I believe the other study came out, um, mentioning how it was, if someone has the expectation they're going to have improvements, they're going to have improvements. And then out came their study that kind of reinforced it, to a bigger, level of it. And well, I think that it's a good study. I think, and I love this study, but I think people are very quick to discredit it when I don't think that we should. Um, because when you look at other medications that are out there, and I'm just gonna, and I don't, I want to preface this with, I am a clinician. I do prescribe SSRI medications on the daily basis to individuals. I'm not biased against them. There is a time and a place for individuals that have the improvement, but then there's the individuals that either don't want to use them or have had bad results and want to go about that and looking at microdosing. Um, but when you look at with the what you saw was that there was people, were able to identify that they were taking a microdose. I think it was somewhere between 70-75% of the time they were able to identify that they were taking a microdose, which then kind of unblinded the study. And people were very quick to point fingers, going, "Well, then where's the blinding's not there, and let's throw it all out." But when you look at the research when it comes to SSRI medications, it is on par with SSRI medications. It's about, with I think it was like less than 5% difference, without having the numbers in front of me, and no one's quickly saying SSRIs are unblinded, so we shouldn't be using those. And I think that if we were to compare apples to apples, it just kind of reinforces, here's the same thing that we're looking at trying to treat in a kind of a similar manner. Why not? And I think it's important to kind of also, footnote that with Dr. Irving Kirsch's work of the placebo effect with SSRIs. I believe it was, he had a couple of books that came out in the early 2000s. In one of his largest studies that he had done, he had collected the information for SSRI medications. And when he collected the numbers that kind of got them FDA approved, he ended up Freedom of Information acting all of the other research that was kind of done that they threw out, with it. So anyone that kind of dropped out of the trials, anyone that, anytime that they did the research and they didn't hit the numbers where, the SSRIs were, starkly different than someone receiving a placebo, they threw those numbers out. They threw that study out, and then redid it.
Jeez,
Yeah.
bad
So
science.
it's bad science. So when you see that, people are 70% of people have an effect with SSRIs, um, others don't, it just kind of reinforces the fact that if the the pharmaceutical companies just kept doing these studies over and over, which are costly, you just have to prove it in 2 studies. You can do the study 100 times. It only matters if you have the improvement, the stark difference in two, and then give that number to the FDA to get approval. So reading through their work, it was kind of like, and sometimes, how are some of these medications really getting FDA approved? Really, how are they getting approved? Why is it? And why are we, why no wonder some people aren't having improvements with it. And I'm not saying it's, it's they shouldn't be getting approved and then they wouldn't have them, but I think it's kind of, when we look at the medications that we have out there, like the SSRIs, it's the same drugs that we had since the 80s, but really they're the same medications we've had since the 50s. That whole monoamine theory of medication. It's just, the tricyclic medications went into the SSRIs, which are safer and have less side effects. Safer as in less side effects and less overdose potential, things like that. So really, I think that someone wants to throw the SSRI or microdosing is a placebo effect. Let's compare it to the SSRIs and kind of go, what else? Let's look at right head. I really think that if anyone wants to spend a few minutes reading the Kirsch's work out there, it's readily available in open access, and it really is. I think it's interesting, kind of looking at it and kind of comparing it.
Well, then it's interesting, even just thinking about the research that came out of Imperial around psilocybin, and that was at higher doses compared to SSRIs. But I guess that fault of that reporting was the measure that they selected, because if they selected any other primary measure, it would have showed that psilocybin actually probably would have been, or yeah, there was better outcome there, if I remember that correctly, and some of the interpretations of that data.
I use that when I teach my classes and I teach about psychedelics. I really encourage people to read that research themselves, because when you end up, if you look at just the abstract of that paper, you'll see that the comparison is the adverse outcomes are similar in the two, percentage wise. But when you really dig into the paper, what you're seeing is people have with the SSRIs are having decreased feeling, decreased crying, decreased sex drive, all of that, as opposed to someone who's taking the macrodoses of psilocybin having an increased feeling of emotions, increased ability to cry, and having feelings of feeling feelings, I guess, lack of a better term. I see patients all the time who, they'll tell me, I'm depressed. I don't like feeling this way, but this medication and this medication make it so I don't feel anything. And I'd rather feel depressed than feel nothing. And I get that too. So I think it's, if you wanted to compare those numbers, yes, the percentage is there, but I think that having a transient headache after a psychedelic trip is and feeling feelings is not the same as not feeling anything, and the inability to cry and
Right.
inability to feel emotion around loved ones and all the other side effects.
Yeah, yeah, I would agree there. So, microdosing psychedelics becoming much more mainstream nowadays. And I think, does this pose a problem with clinicians and therapists of like, how do I talk about this stuff? And it seems like, your book is a good guidebook for people to get educated and learn maybe how to have these conversations, to have all that information. So, as a practitioner, what do people maybe need to know about psychedelics when they're talking to their client? And then on the other side, like, how do clients talk to their provider around, psychedelic interest?
Well, before I answer that, I do want to tell a quick little funny story. My first patient I ever saw as a new clinician, like literally, my first patient, I come in, I'm starting to talk to them for the first interview, and I got to the point and I'm asking them, where are we going? What do you need? And they said to me, they go, "Do you know anything about microdosing?" And I kind of chuckled and I was like, "Yeah, I do." And my book hadn't come out. I had the deal, I had the time, and I said to them, I go, "Yeah, I know a little bit. What do you know?" And I kind of wanted to get what their input was. And and the interesting thing is here was this lady, upper middle white class white, and in her 60s, was not expecting this out of it was not what I was expecting, I'd have to say. And so I asked her what she knew, and she kind of like she knew quite a bit, and I was kind of really, and she goes, "What do you know?" And I kind of just said to her, I was like, "I don't really know how to kind of put this. I wrote a book on it and it's going to be coming out next year." And she looks at me and she goes, "You got to be effing kidding me." I go, "No, I'm serious." And she's like, how do I even prove that?" I go, oh, you can look it up on Amazon. And she sat there in the middle of the appointment, looked it up on the phone, and she just kind of goes, oh my God. And she goes, I guess I came to the right place. And I was like, yeah. And not wanting to tell her, you're my first patient I've ever had. Like, you are the first one I've ever seen independently on my own. And so I was just
It's
kind of like,
amazing
yeah.
you attracted that type of client for your
Well,
first
it
first.
reinforced my feeling of like I'm doing the right thing. Like once again, here, you know, this career suicide I've thought of like going into working with psychedelics and being kind of open and talking about it. Here, my first patient's talking about it. It's got to be, you know, it's serendipity. Like really, it was. And so I wrote about that actually in my book, and I still haven't told her. And I know that she read the book, but I don't think she put two and two together that it was actually her as my first patient ever. Um,
Well, if she's
but
listening, now she
I hope
knows.
so. Yeah, yeah. Um, so I think when I ended up putting the book together, um, one of the questions I had with the publishing firm is they kind of were like, you know, we love the book, we love how you've kind of put it together. It's a little heavy with the citations, and wanted to cut that down for you know the sake of just saving room for words. But the other part there was like, you know, the second part, do you really need this for the clinicians? And I was like, this is really the point of the book. Like without this, it's you know, it's not meaningful to the point where it could be useful for people. Anyone can put a handbook for people to learn about it. But what made this different was that the clinician can kind of look at it and help answer these questions as well. And it's written, that second half of the book is written at a little bit of a higher level per se. I use a little bit of bigger terms, but I also cite my sources so like someone could see where I'm coming from. So a clinician can go, oh, I don't necessarily understand or agree with some of this, but I see where you're coming from. I'm okay with this. Or want to be able to kind of, maybe I can explore this myself and kind of go into the research themselves. Um, so I think it's important for clinicians, and that was kind of when I did that second part of the book. I wrote a little bit of a message to the clinician themselves saying, you know, here you've got someone who's coming in, you might not be completely open to it, microdosing or psychedelics in general, but you need to kind of have this approach of meeting the patient where they are and understanding that just for them to come talk to you is a huge deal. Because there was one of the studies that came out about microdosing, I think it was like somewhere between 20 and 25% of people ever talked to their clinician before they started microdosing. And I tend to believe that's probably even high of a number because I think a lot of people just don't have that conversation. So I said to the clinician, you know, be open to this and have this as a, you know, a risk reduction approach. And I like using risk reduction versus harm reduction because the psychedelics are not inherently harmful. There's risks involved, but they're not harmful. And I think changing that term can kind of help soften it a little bit so people feel more comfortable with it. Um, but you know, I said, here's this risk reduction approach. Like just like when you have a patient who's coming in who's might be drinking too much, smoking, using opioid medications, using heroin, whatever, you're going to talk to them about how to minimize these effects, how to have a healthier approach. You can also have that with psychedelics. You can also have that with microdosing, and here's how to kind of have that conversation. And if you don't feel comfortable having that conversation, is there someone else that you could maybe refer them to as a colleague or a different place so they can get those answers? Because if you just shut them down, you know, the risks are going to go up. You know, people are going to
Well, just
not feel
thinking about
comfortable.
like yeah, therapeutic relationship,
Yeah.
right? And you know, do you feel comfortable with your provider? And I think that's a really big deal. And I think it's an important reminder. You know, I'm sure lots of people that are listening already have an interest in psychedelics here. But yeah, for those that like don't, I think it is important. So people like clients and people that you're working with like feel heard. They don't close down. It was really interesting. I just went to my primary just for annual physical and checkup, and they're just doing like depression screening, and it's just been a little tough lately. And so they mentioned, "Oh, do you want anything?" And I was like, "No, thanks. I just started some ketamine treatments for that." And sometimes I just like to toss stuff out there to see how people respond. And they responded in such a positive way. They're like, "Oh, wow, that is awesome! Like I've been reading so much about like the efficacy of that, and it seems like there's really great results." And to feel heard as a patient or a client, I was like, oh, that feels actually really good, instead of like, whoa, what are you doing, and having a little bit of fear. That probably would have shut me down in that relationship. It's like, how do I want to share with like the physician moving forward? So to feel that support, actually, it felt for me, it like actually opened up the relationship a little bit more of like, oh, like I feel like I don't need to hide how I'm treating myself, or what I'm interested in here. I think that's really important.
Oh, absolutely. I mean, we have to realize that, you know, we're also clinicians are coming out of that, you know, this is your brain on drugs, war on drugs, drugs are bad, and learning this themselves. And I think that clinicians need to also realize that, you need to be open to learning as well, and kind of like changing the narrative, and being open to what's out there and following the research that's out there. That's why, like in that section for providers, I put in there, here's some of the different organizations that are looking at, like the Psychedelic Medicine Association, um, other educational places that are doing this for therapists or for clinicians to kind of learn. I put in there, I believe I put in, the Vital wasn't out yet, but clinicians for and therapists program.
Yeah, that is
Um,
in there. Thank you for that
yeah,
shout out.
of course. Yeah, I put in there also Ben Malcolm's website as a place, because people that don't
That's
know,
an
Spirit.
awesome resource. I mean, that was like really helpful, just to refer clients to when it comes to medication contraindications and all that stuff. I'm like, Spirit Pharmacist, go check that stuff
It
out.
is the resource. I mean,
Yeah.
literally. I mean, he is. Yeah, and I've talked with Ben many times about this. I go and I do presentations now, and people are like asking questions. They go, "Hey, have you ever heard of?" And I'm like, "Yeah, I know Ben. I know Spirit Pharmacist. I know Ben." And just kind of like, people know who he is. People know, and they're just like, it's a great resource to have. And here, you can have this as a clinician. You can get his free resources of drug on drug interactions and stuff in a super handy model for it, and have that as a resource to help people. I mean, that's a great start to begin with. If someone had that and a patient goes, I'm looking about going on an ayahuasca journey in a couple of weeks, and I'm kind of nervous, but I'm excited, and they haven't answered my questions yet. I have an appointment. What can you help me with? I mean, that can start a conversation of how to kind of start going down on SSRI medications or whatever, and why it's important. And then the clinician can kind of feel a little more comfortable of, here's the science behind it, and it's not so odd that you're going to be going to do it, and you're going to go feel and being safe about it. So really, by changing that narrative, it can be huge, and just by normalizing, people use for different reasons. And if you have a background and understanding of what they do and why, it can kind of be hugely beneficial as well. So just, getting clinicians to feel comfortable having these conversations.
It's so important. I know a lot of folks are also worried about like, if I bring this up with a client, if I talk about this, is there a risk of like losing my license? Like, what are there risks actually kind of being open to clients if they're asking? Like, if you're not obviously just saying, hey, you need to learn about this, but if clients are bringing that into the room, is there, any risk there with licensing boards?
I think, when you look at the licensing boards and what's out there, every state is different,
Yep.
and you're looking at,
Every licensing
this.
board's different.
Every
Yep.
licensing board's different. But if I think that if you can kind of approach it in a, here's the science behind it, here's where I'm coming from, and can justify it. It's just like, as a clinician, prescribing medications off label. You can prescribe medications off label, like when you're doing ketamine for depression. It isn't off label, it's not FDA approved for that. But you can go into, here's the research behind it, and here's why I'm prescribing this. It makes it a little more comfortable. It makes it so, at least you can kind of go, I'm not just pulling this out of the air. Like there's the science behind it. This is evidence based, and have that comfort level to it. So and every state is going to be different, and you have to be able to justify it if it comes to the board, to a board of your peers, and if you can
Hmm.
kind of go with where that's at, I think you know, you're better off having that conversation, and you're better off being able to have that being defensible to it. You
Yeah,
know,
yeah.
it's
I haven't
because
heard
also
of
you're
too
not
many.
prescribing it. You're not
Yeah,
prescribing it either. Someone's going to go out and do it on their own. It's not like I'm writing here, go out and use psilocybin. Here's the amount, or here, go use ayahuasca, etc. I'm saying here's where to kind of uh, have your best chance and your best outcome, and then when you go do it, you're less likely to have a side effect.
right. And I think that's a really important thing to remind folks that maybe are, working with clients is like really kind of staying within your scope and thinking about language and how you talk about this stuff and thinking like, oh, did I just tell, so and so to take, X amount of grams of mushrooms, right? That could possibly come off as prescribing, this type of treatment, or saying like, oh, you should do this to treat X, Y, and Z, and coming off as kind of like a prescription. So I think language is really important in how we talk about that. So yeah, just some good reminders for those that are working in it. But also on the other side, it's like, is thinking about like, ethical, actions here. It's like, looking after client health and safety. It almost feels like a little unethical to not even, provide any sort of psychoeducation or harm reduction, if you have those competencies and if you know about it, right? Versus like if your clients are doing some of that stuff, like I don't know, it feels like you're looking after a client's safety and health, and you would want to provide them with information, and that could just look like pointing them towards research and resources, right? And letting them know the potential risks and how to navigate that to have the benefit.
I encourage patients all the time to, cut down on your smoking intake, and if you need something like nicotine replacement, I can prescribe that. Cutting down on alcohol intake, and if you need a medication to help you with that, I can help. There's medication out there for it. Or if someone's using opioids and they're injecting, you know, unfortunately, there's not, we don't have safe injection sites here this time, but, needle exchange, things, like that, that's very similar. I'm not condoning the use necessarily, but if you're going to go do it, be safe about it.
Yeah. So how do clients, I guess, talk about this? Like, do you have any perspectives or advice on that, about even feeling comfortable of opening up, how to really address it with their providers or therapists or whoever they're working with?
Well, I know kind of, yeah, like you said, kind of feeling out the room and kind of like seeing how they kind of go about it. I know that there's like clinicians that will leave hints in their room to kind of feel comfortable. I think Andrew Penn had mentioned before, and he's been on the show, Psych NP. He has a copy of PCAL and TCAL in his office that he sees patients, and if people know, they know. Um, I've got like a copy of the cannabis nurse. The Cannabis for Nurses book in my office. I have my book in my office, things like that. Um,
Yeah, my
but
supervisor would print out like some of the most recent research articles and place
yep,
it in the office waiting room so people could read it.
exactly. If you can make it as friendly as you can for it, whatever that might look like, whatever that might mean for you, um, that's kind of be maybe even if type of situation. But I think for people, maybe even having that conversation of kind of just going, I often will hear people will phrase it as, I have a friend who, and they're just kind of like, and I have a friend who I knew I was coming in to come talk to you. They said, they aren't going to see anyone for a while. They wanted to know, about this. Could you help me kind of have some information about it? And kind of put it in the third person narrative that might be a little
Yeah.
helpful for people.
What's the Reddit acronym? Usually swim, someone who isn't me.
Yeah,
Swim.
swim.
Yeah.
Yep. And just kind of hypothetically, here's what I'm thinking, or here's what I'm interested in, and it's not me, of course, but, and then kind of, when I have patients that do it, I'll either, if and I'll play along with them. I go, well, okay, since it's not you, do you know if they have, or would they be interested in Oh, yeah, yeah, yeah. And if you want to do it in the third, and that might be the best, that might be a way to kind of feel out the comfort level to it. Um, I've had patients in my first interview when I'm talking about drug use, they'll kind of minimize it, or they'll be like, yeah, I did LSD back in the day, but I haven't done it recently. And some of them will. I had one lady. It was cute. I was not expecting it. She was in her like late 70s, and she was telling me about her first time with mescaline and kind of how that was, and I was like, wow, I was not expecting that. I feel better for hearing this. I mean, this is you don't get to hear a mescaline story very often, but yeah, I think that might be the kind of the way of going about it, is just kind of feeling them out and until and just kind of seeing, because every provider is different and their comfort level is going to be different. And that might be a good point for having education for the patient to the provider, and just saying, maybe, in the future, here's some information that you could learn from it, because they might not know either. This is an area that is growing. And I think that sometimes we forget when we're inside this world that everyone's not inside this world and not
Yeah.
everyone knows.
Yeah, yeah. Sometimes you think like, oh, everybody knows about this, or all clinicians and therapists and providers are researching this, and the reality is probably not. It's still it seems like it's really out there, but it's also kind of still small and grow.
Well, I learned that in one of my first talks I did when I was doing an education on psychedelics to a group of psychiatrists and psych nurses. And here I was talking about psilocybin, I was talking about LSD, and when I opened up the question at the end, I was like, any questions? Someone goes, so when we're talking about LSD, are you talking about acid? When you're talking about psilocybin, are you talking about mushrooms? And I went, oh my God, yes. And I was like, and that's why, like, my first slide when I do this is like, I kind of go, here's what I'm going to be using for these terms. These are what they might be known for colloquially, and kind of go from there, just so people know, like, so we're speaking the same language, because people just don't necessarily know that. It's
Yeah,
tough.
yeah. We got to remind ourselves like we are in a bubble sometimes, and
Oh, absolutely.
how do we bridge that gap? I see we have maybe I don't know a little over 5 or so minutes, or probably we could go a little over, but I know we did want to talk a little bit about accessibility and scalability. So yeah, what are some of your thoughts here? How do we scale psychedelics in clinical setting and bring it to the people, and how do people get access to it?
I think that one of the great ways, I think, and I might be partially biased to this, is being able to use nurses and using nurses to their full licensure and what their benefit is. Um, we don't know yet how, if these substances become approved, what that will look like, and what the FDA will put for um, restrictions around it. But when you have like advanced practice nurses who are performing psychotherapy and have can prescribe medications, that is a perfect gap to be able to scale this and have it more accessible to people. Um, Having one of the clinicians that are in the room being a registered nurse, if they're not able doing the psychotherapy, they're able to be sitting there with them, having that authentic presence, being present throughout it. And I think when it comes to nurses specifically, it's not abnormal for us to be around people with altered mental states or expanded consciousness. I mean, if you can sit with a patient who is admitted to the ICU for delirium, there's not much of a difference with a medical delirium than someone who is using psilocybin, MDMA, things like that, and being able to be present with them and in the moment. When you look at when it comes to nursing, research, the early research is lacking telling a huge narrative of it, but nurses have been sitting there, and I'm talking Western medicine's approach of it, not indigenous use, which can be very similar to nurses in some ways. But when you look at like the early research with LSD, the psychiatrist on the wards would be giving the medication and then having contact, but they would be off doing other tasks on the units or throughout the hospital while the nurses are sitting there. When you look at A lot of people, a lot of the research doesn't exactly tell what the story or what the nurses were doing. Some things you'll see in the research, like a line about the nurse would be sitting there taking notes and offer support if necessary. Um, in other times, you had the nurses who would be on the unit doing the active work, like Kay Parley, who was working with Osmond out in Saskatchewan, and who is still alive at 98, 99 years old now, and has a book out talking about it. Nurses, and we've been there since the beginning on the wards because sitting there for 8 to 12 hours, it was too tiring for the physicians to do also, which nurses, that I could see nurses going, wow, I get to sit for 12 hours while I'm sitting there with them. I'll take that as I'll take that. That sounds like a better approach. That's unheard of for them, but to be able to have that authentic presence, being there interacting with the patient while they're doing it, and being that tethered to the natural world that's going on. There was a great paper written by Laura Berg, who she did 2 parts for MAPS back in '94. Um, she was a nurse that was hired on part-time working with Rick Strassman in the DMT research, and she referred to it as flight nursing because you're sitting there talking to the individual as they're going out on this trip, and you know supporting them for their safe return and making sure if they have any problems, I'm sitting there with you and you know that you are safe. And I love that term.
Flight nurse, yeah. Yeah,
Yeah.
it's why do you I feel like, I've talked to a lot of nurses over the years and it feels like they feel really confused on where their place is in psychedelics and it almost feels like they feel excluded at times and why do you think that is?
I think we get forgotten at times. I think, and that's part of it. I know, like when the MAPS protocol came out and they were looking at doing it, they inadvertently left nurses out, um, despite Annie Mithoffer being, the
Being a
principal
nurse.
investigator
Yeah.
with Mike, and she's a nurse herself, and it was kind of like, oh, we forgot that, and then they added it in there. When you look at I'm in the CIIS program for clinician for psychedelic therapies and research program. And one of the heads of our program, Janice Phelps, wrote this great paper back in 2014 for the role of clinicians supporting psychedelic journeys. And in there, she describes how nursing is a perfect fit and the
I think
competencies
so,
that are
yeah.
needed. Yeah, I think that we just forget about it, and we just we need to advocate for ourselves, but also nurses are notorious for not um, using their license to the full extent. Either that because of the institution themselves, or because we just kind of don't speak up about it. And I think that this is a time that we can kind of speak up and go, "Hey, don't forget about us. We have this experience. Let's do this. Let's see how we can kind of go about this." And a lot of the papers and a lot of the research is done are authored by nurses. There's nurses on staff at USONA and across the board that are involved, and we just kind of have to be be open to it and kind of like advocate. This is what I would like to do, and kind of let's do this. Let's see what we can kind of go about it. And I think it's a perfect fit.
Some of the retreats I've been on that had nurses, I was so thankful that they were there. Especially like when there's just been like, just injury that happens like outside of experience. And nurses just being able to go in and help. I remember being on a retreat and there was a physician there, but somebody got hurt. They fell, and this wasn't any substances involved. It was just during recreational hours when we were doing stuff, and the doctor was like, I haven't stitched anybody up in a while. It's usually
Yeah.
the nurse's job, and it was like so nice that we had nurses on staff, or even at a breathwork thing.
Yep.
Somebody was leaving and they dropped the luggage on their leg, and it was like, oh, thank God there was like some
Yep.
medical people on staff that could help out with that. But yeah, I mean, in your training, right? Like, nurses are so caring. They're there to care for people, and that is a huge role. And I think it's like well positioned. I think probably better positioned than say a therapist at times. If you do have that caring nature, you're medically trained, and for some of that sitting and guiding, maybe you're not doing as much psychotherapy.
Yep.
Yeah, I think it's a wonderful profession to get involved here.
It is that perfect fit, the medical background, and then you just, with the the history of caring. And for any nurses that want to go in and look at it, the nursing theory, once again, Andrew Penn had a great paper on Watson's Caritas model of nursing theory and what it means and why it's a perfect fit for psychedelic work. And it's just amazing if you're looking at that and kind of go, oh, this does make sense. This makes sense of why we can do what we can do, and just authentically present with the individual and just support them throughout the journey. And I think if you think of nurses, we're kind of, for the most part, unruffable. Like something can kind of go up and you just kind of go, oh, okay, this is kind of part of the deal.
Yeah.
This is happening now. Okay, I'm going to respond, instead of going, oh my God, what am I going to do? Internally they might be screaming, but you don't see it. They're kind
Right.
of,
Right.
they have their game face on and wait until afterward and go, oh my God, that was the worst thing I've ever seen.
Right. Right. Just jump into action.
Yeah.
Um, yeah. And then on the scalability issue, I mean, I feel like we're talking clinical scalability, right? Like I think there's other ways for accessibility, like community kind of religious kind of acts. But just on the clinical perspective, yeah, I think, the big barrier is going to be cost of treatment. It's going to be very expensive for people to go through psychedelic therapy. So that's one. It's like, how do we reduce the cost? And when we think about, to go back to our other topic around, non-psychedelic psychedelics, but thinking about kind of the different biotech plays that are happening to find, maybe an LSD derivative that's shorter, right? So clinically speaking, like, when do these shorter trips could be more appropriate. That is one thing that I do like about with working with ketamine is it's a little bit shorter acting than say it's like 2 hours, 2.5 hours. A client is in and out of the office. But versus like MDMA or psilocybin, right? That's more kind of resource intensive on people. It's longer, and that's going to cost more money, right? Because we're paying for a therapist's time, a nurse's time, a psychiatrist's time, whoever's doing that type of therapy, and that's really going to add up. So could there be that use case for shorter psychedelics in the clinical container?
Well, I
Um,
think if you look at, I mean, ketamine, I think is a perfect example of, you know, when you look at like S-ketamine, the cost of it is absolutely ridiculous comparatively. So when you look at the cost of ketamine, the drug itself is inexpensive, but to get the treatment, the expensive piece of it is not the drug. It's everything else that goes around it. It's having the support there, having the staff for the time and everything. Ketamine is like less than $20 for uh for the psychedelic amount, or the full dissociative, whatever the term you want to use with it. But the therapeutic amount is like $20. So it's, when someone's going in, and then because of it having to be cost out of paying out of pocket, just makes it so it's less accessible for the people that might actually arguably benefit more or need it more. So I think that's kind of where we need to have these conversations now, because with ketamine, it's we see the issue, we see the just the lack of access that's there, and why people can't get to it. But when we have the scalability piece to it, it's going to be, how do we go about having doing more group work. I want to see research being done on group work. If you can do anything to change the ratio of 2 to 1, if you can have, 5 to 2, or whatever that might look like, it can lower the cost, lower that barrier. And then you have, as you're doing it in that group work, there's the benefit of having group work and group therapy as it is anyways. I think that's the good thing about having, group psychotherapy is you're modeling how people should interact with one another, and kind of having those interactions and having that village that we don't necessarily have in Western medicine
have
too
yeah.
much. To have someone to go into doing, intensive outpatient, to doing the group work, stuff like that is another barrier that's there. And some people that would benefit the most would often don't go into doing that. But having that, having to model how to have those conversations with loved ones and family members and etc., is one of the benefits of the group therapy. And if we can put that in with the psychedelics, people won't feel so alone, which is one of the largest reasons of depression, from either the effect of the depression or secondary to depression. And we see that now with COVID, how much people feel more alone and the result of their mood changing because of it.
Yeah. Yep. Two things come to mind too. It's going to be interesting to see Oregon come online because, that they're incorporating facilitators that won't always be clinically trained.
Yep.
And I know, there's a lot of different opinions there about that, but that does, open up the field for a lot of people to get training, to enter into that role, and maybe not paying, the price of, a licensed therapist, a psychiatrist, a nurse, where it could be a little bit cheaper, and then, being done in that group model. So I'm just curious to continue to follow what's happening in Oregon. If, Colorado voted yesterday, we were recording this on the 9th, and I think they're close. I mean, last time I checked, they were winning that Proposition 122. So we'll see if that passes. But I think that's gonna also be the future. And one other comment was, when I was working with people with early episode psychosis and this house that opened up, one of the selling factors was that, well, it was maybe not so much a selling factor around peer support, but just the importance of peer support. You're talking about community, was that they were able to offer a model that was cheaper than, putting somebody in the psychiatric unit or going through the hospital, because, the amount of money it costs to have somebody in there for a few days is very expensive, because you're paying for all the medical, all the medical stuff there. And so, where I was at, we were able to provide care, community, and support for, I don't even know, it was, half of what, or more than what the cost would be for somebody that would go into the hospital. So I would love to see more of those kind of community oriented facilities opening up. Peer support, obviously have people trained properly so they're able to do that type of work. But I think if people do really want to scale this, we have to think about the diversity in the field, the ecosystem, where people want to have services, what type of services are going to be provided, kind of staying in our lanes. Because some people are going to want that individual ketamine-assisted psychotherapy. They're going to want individual support. And then other people are going to maybe want more kind of group, more peer support, community support.
If you can get them admitted to the hospital as well. I mean, I see patients all the time. I'd love to get admitted, and just there's no beds
Right.
for people to get into.
There's no beds, yeah.
Yeah, and I, listen to the model when you've described it before. I think it's just amazing, just having that group model there. I mean, it takes me back to when I was in college. One of the times I had one of my fraternity brothers who had schizophrenia that lived with us in our fraternity house, and it was amazing to have that as a container for that support for him, that we were there for him, in helping him and keeping him doing well in that pathway to health. And and it was kind of puts me also to think of, like, when it comes to the stigma of mental illness. I remember it, and I'll never forget this. At one time, he ended up having a little bit of a psychotic break when there was a party, and he ripped the door off of the room that everyone was partying in.
Whoa.
And
Jeez.
because he thought that there
Strong
was a
guy.
fire. Yeah, and kind of like everyone, like, no one wanted to say, he was psychotic. It was like, yeah, he dropped LSD earlier. People were like, oh, okay, that's cool. Yep, no big deal. And it was just like, oh. I wonder how that would have gone over if people knew that he was really psychotic, and kind of like, here's that
They probably would have freaked out a little bit more.
Exactly. So it really was a good humbling experience of, going in, not like in my history of living with someone with it and seeing, like, the rest of it outside of, like, the inpatient setting was an amazing, awesome experience to have. But yeah, I think with Oregon, it's going to be interesting seeing how it goes. I think it's going to be it's going to be a good model here to see how we can probably go about it, and hopefully get this as something that people have access to. And once again, with having the whole plant medicine, and that's something we didn't even touch upon today, was the difference between the synthetic. But having, with growing the mushrooms can. can be so much. It gets rid of that restriction overhead
It's more
because
cost
so
effective.
much more
Yeah.
cost effective that to be able to have it and grow it yourself and have that access that's going to be there instead of having to go and get it chemically made for research, which is so inexpensive overhead to begin with, and one of the barriers for having research not being able to be done. So
Yeah.
yeah.
Awesome, CJ. Well, we're over time, so I also want to just, if people are watching this on YouTube or anything, just holding up your book again. So definitely check out the Microdosing Guidebook. CJ, any closing thoughts? Where can people find you? Anything that you want to wrap up?
Well, my book is available everywhere, luckily. So, support small businesses. If you go in, because of Simon and Schuster distributing it, you can get it at small bookstores, which I think is helpful because then, they might order two and have one on the shelf to have more accessibility. So support small businesses. It is also available at, all major places, including Amazon. I'm available everywhere. All of my social media is at EntheoNurse. It's ENTHEONURSE for all of those. And that's my handle. My website is entheonurse.com, and I'm pretty receptive of people having questions, answering, how do I get into this field? How do I go about this field? And helping along with that.
All right. Well, CJ Spotswood, it's been awesome. Thank you again for your time. And yeah, excited that we finally were able to get you on the podcast.
Yes, thank you. Thank you, Kyle.